So the biggest limitation that we currently have is the under-recognition of sleep disorders. So that healthcare professionals are not really picking up those symptoms, are not really picking up those first signs or complaints, because it is not in their standard protocols, like asking, how did you sleep? How is your sleep? How much do you sleep? When do you go to bed? When do you wake up? How do you feel when you wake up? Already throughout childhood, are there certain, is it insomnia? Is it difficulties falling asleep, maintaining sleep, waking up too early? Is it a sleep disorder breathing? Is it more neurological in terms of, the sensations in the legs? Is it tossing and turning in bed? So these are questions that should be standard in any healthcare profession protocol, asking about sleep. The next step would be, then to refer them to the specialist on that. So this is the first bottleneck. The second bottleneck is that we are defining sleep based on EEG, polysomnography, which means that we need to have the polysomnography. We need to send you to the sleep study, or we need to have the mobile equipment to do the recording at home. Or we have a semi-objective, the actigraphy that is being worn, which is measuring activity and non-activity. So those are the limitations in terms on how we measure sleep and in which setting we measure sleep. So first of all, polysomnography is expensive and is mostly done only when there's really suspicion of a sleep disordered breathing. But that does not mean that you should not inquire about it, or you cannot put like a semi-objective or a questionnaire to get a bigger picture of where are the bottlenecks or where are the complaints and where should we work on. Is it more on the falling asleep? Is it more on the sensations overnight? So all of these different components. So these 2 points are very important. And then the third point is then how do we treat? So first we try to filter who is really referred or needs a referral to a sleep clinic or needs a referral to further investigation on sleep. And then the second one is, okay, how do we then start a treatment? So because if you refer to the sleep clinic, you very likely will have a diagnosis of or not of a sleep disorder. So then the treatment comes. And the problem with the pediatric population is that contrary to adults, in adults we can give medications, we can do cognitive behavioral therapy, but with a child you work with the family, you work with the child in a context of a very complex context of a family, especially in the 21st century. And so that is a second bottleneck. So which kind of treatments do we have? And we do not really have medication like a sleep pill valid for the pediatric population, but we do have, alternatives and approaches that we can offer, and most of them starts with, a good awareness of what sleep is, the importance of sleep, the sleep hygiene elements. So working more around the context of sleep and how sleep should be happening and the behaviors before and after sleep. And then of course looking into more, especially with adolescents, more in that cognitive and behavioral elements that we can implement stepwise together with the family and the child to come to that success. That is for typically developing children, for children with neurological disorders or with an atypical development, so with an developmental disability, it is even more challenging. And so there are even more issues that we need to solve, because can we use the same cutoffs of typically developing children towards a child that has a severe psychomotor disability, because the way that they are positioned in their wheelchair, the way that they are putting to bed in their beds, in their sleep environment. So these are all confounding elements that are added to that and makes that picture even more complex. And that is why you need a multidisciplinary team looking at this with that sleep knowledge to come in, okay, this is important, for sleep, a side position, prone position, supine position, all of these elements, the breathing, a little bit more upright, a little bit more down. So these are components that a sleep expert will bring into your multidisciplinary team. So for those children, it's often that we use melatonin. Melatonin as an hypnotic, but melatonin is a hormone and should not be prescribed like just random randomly. It's a chronobiotic, and it needs to be, not only the dosage needs to be very well defined, but also the timing where you give it. And this is something that is a very hot topic in the field, because there is no other drug except that physicians try other combinations of drugs that have a hypnotic effect. But is that really a clinical trial and with effectiveness and a good science behind it? We're not there yet, but it is in clinical practice and it is within clinical experience. And that is why I'm also doing this, is to bring in those experts that are encountered with children with developmental disabilities, with these issues and potential sleep problems. If you inquire about it, then try to find that sleep expert in your vicinity so you can exchange ideas. What is the next best step forward? Because a child with a neurodevelopmental disability that has a sleep problem and is living at home is a problem of the entire family, and even further of the entire society, because you have a parent that is sleep deprived going to work. So my aim is really to advocate that we try to get more disciplines involved, that we exchange our knowledge and try to find the best solution, because right now there is no science saying like, okay, for this kid, this disability, that is the treatment. So we're in the process of getting there, which means that we need that clinical experience and the discussions.